Hello, everyone. My name is Dennis Feldman with InstaRisa, and I want to welcome you to the first installment of our Face the Future webinar series. The concept we have for these webinars is that every time we get together, we'll feature a different guest host who will be speaking on various aspects of dentistry. While the hosts and topics will change, we'll always focus on utilizing 3D facial scanning technology. We hope that you will find these webinars informative and entertaining. And again, thank you for tuning in. This evening, we're going to be learning about beautiful and patient-friendly FP1 restorations. Our guest host tonight is a brilliant clinician who has an interesting background. He focuses every day on merging the art and science of dentistry. And through that focus, he's become an expert in digital dentistry and in CAD design. He began his career as a research engineer with the U.S. Army Corps of Engineers. From there, he took his engineering mind to dental school, graduating from the University of Mississippi Medical Center School of Dentistry. Currently, he has a private practice in Flowood, Mississippi, and he also does a good bit of speaking and education. He's currently faculty with the Atlantic Implant Institute in Virginia. And tonight, we're very excited to have him speaking and educating all of us on this webinar. With that, I'd like to turn it over to our guest host for the evening, Dr. Keith Klaus.
So, my name is Keith Klaus. It's an honor to be able to do this and kick this first one off. I'm sorry, I'm typically pretty technically gifted, but for whatever reason, I can't seem to figure out Google Meet. But today we're talking about something that I really enjoy because it really is the most complex when it comes to at least prosthetics, with full arch surgery, and that's fixed prosthetics FP1. And so this is a topic that Carl Misch really classified, fixed prosthetics into three classes: FP1, FP2, FP3. And so what you're really, discussing here is, what are we restoring? Are we restoring just the teeth? Are we restoring, a long tooth? Or are we adding pink to our prosthetics? And there's different clinical indications for each of these. And for the longest time, and what you still see, out around a lot is this FP3 design. And it's kind of become almost a one size fits all in a lot of offices. One thing we're proud to deliver, here in Flowood. I work with a really good clinician, two really good clinicians. Dr. Greg Tharp's a partner, of mine for several years, and he's a board certified prosthodontist and also certified with, he's a ABOI diplomat. And I've had the pleasure of working alongside him and really kind of developing, these protocols, over the years. And, this is kind of where we are now. All three of these cases were done, this year. And so these are showing, FP1, FP2, and an FP3 approach, all for different reasons, all for different indications, and also, all trying to, maximize the treatment for our patient. So this is kind of, the goal here, right? This patient was 37 years old when we started her treatment. She had, bad bowel estrogen syndrome, a lot of decay. We went through, multiple rounds of trying to, save her teeth, caries control, and ultimately decided, dentulate, dentulous options was her best bet. This case was, sequenced, so where we used her natural teeth to hold a provisional while we placed implants. Took a long time, a lot of treatment planning, but my goal here was, at 37, I'm going to follow this case throughout, my career, certainly. And I'm going to expect something, to last for her. And, she lives to be 80, 90 years old. What's the chance that we're going to have some type of revision? And so in my mindset, if I can give her, more chance for a more productive outcome, long term, I'm certainly going to do that. So how do we choose, right? So FP1 versus FP3. It's a patient that I treated, and I got lucky here. But you're seeing progression. Far left screen. This is how she presented And so this case was done probably 2 years ago or so. She came in, with a partial, so a class 4 partial. For 30 years she was a dentulous, and so I low lip. This was as high as I could get her to raise her lip. And that middle, or that second image from the left, is showing an FP3 prosthesis.
Hey,
and
you want to advance your slide, buddy? I'm sorry, we're still on the title slide here.
Oh goodness. So I was on this slide. I'm just going to pick back up. So with this particular patient, we started off with an FP3. 3 months later, the lip, this lip position pretty much dictates, most of what we do when we're designing, facially generated, designs with these. Excuse me. And so what I noticed was, we've got a transition line showing, and that's an immediate aesthetic failure. And lucky enough, I was able to widen the teeth, lengthen the teeth, and we were able to almost reverse it or engineer ourselves into an FP1. So when to do FP1, for me, it's anytime there's a really high smile line, or if I have adequate bone and soft tissue, where I feel like we've got a good long-term outcome. And in this case, certainly turned out a lot nicer than it could have, had we gone in and done 10, 12 millimeter bone reduction. So this is what her provisional looks like, at our delivery appointment. And by the time we went to zirconia, these little pseudopapillae had filled in pretty nicely. I guess I could have posted this slide 15 minutes ago when we started this, and I was fumbling with everything. But for me, I'm young in my career, and I'm humble enough to know that I don't know everything. So a lot of this with the FP1 for me is a work in progress. But I want to share some of the challenges that I've seen, and how we utilize the 3D technology, how we utilize CAD/CAM, how we're able to use facial scanning, in a digital workflow to decrease the complexities of FP1. So starting my journey, like most, single teeth implants, and with that, the single anterior implant is one of the most difficult. And so I really kind of follow this dual zone therapeutic concept, that Dennis Tarnow and his group with Salama and Chu and the rest of them. And that's basically you place an implant, graft the gap, try not to disturb the periosteum, there, minimal flaps. And this one I did a little tunneling and a connective tissue graft just because he was so thin. And then of course, here we are 4 months post-op. This is predictable. This is easy. This was, predictable in my hands, and kind of helped grow my skill set to where I'm ready to take on, a little bit more, complex. But everything starts with the prosthesis. So we able to design a prosthesis. We can make surgical guides, and we're lucky enough to be able to, present, cases like this, to our patients, and get a really nice emergence profile. Again, I didn't do, there's no connective tissue grafting here. This is simple. This is, kind of, I guess, this is how I cut my teeth on, implant, dentistry and prosthetics, leading up into FP1 cases. Soft tissue management, where we know that we can get, really nice papilla next to natural teeth, because we have the bundle bone and everything is present. Our crestal fibers attach into the natural teeth. We don't get that with implants. So often the soft tissue management is paramount. And so this is a case just showing how just flap design and simple manipulation with the apically repositioned flap, we can generate really nice thick connective tissue to support these. But when I look back at this case, this is a 4-unit FDP, but what's the difference between this and doing full arch? So this is kind of where where my head goes when I'm approaching these cases. You know, look back on my cases in the previous, you know, in the past, and you know, help utilize those to, you know, treat these, you know, in the future. So, emergence profile design. I really like, you know, this paper, and I was fortunate enough to meet Ramon Gomez Meda and Jonathan Esquivel earlier this year. And, you know, this isn't necessarily a new concept, but I do like the way that they highlight these different zones, you know, for a single tooth. So, you know, with that, we've got a, you know, crestal zone, which is just immediately apical, you know, to our implant platform. And that leads into, you know, what they call their bounded zone. And then finally the aesthetic zone. And really what we're trying to, you know, accomplish here is set parameters, you know, for different implant types, different implant, you know, designs, different abutment designs. And every case that we do is, you know, at least in our office, uses a multi-unit abutment. So at some point you've got to, you know, correlate this and make an association between this type of concept and utilizing a multi-unit abutment, and then a prosthesis that goes, you know, on top of that. In addition to where the implant positions, you know, we've got to pay, you know, attention to our ponic design. This is another paper by those two for boosted sites, right? So, you know, periodontally boosted sites where we've done connective tissue grafting, as we encounter often, you know, in a dentulous case. And so if you can, you know, visualize this, making a flat ponic design versus a step ponic design lets you have a little bit of leeway in, you know, where that soft tissue drape is, you know, for our gingival margins. And then the next important thing is how close to the bone do we need to be, right? So this is a paper by Alessandro Pazzi, and in this, you know, paper, he's basically showing that, you know, when you get too close to the bone, you start getting inflammation and ulceration. And so the magic number, you know, that he found was around, you know, 2.26 plus or minus 0.6, and that's a pretty good, you know, variance there. But the idea is we're, you know, again, I'm trying to put all these different concepts together to treat, you know, a full arch. So here's a case, and this is probably, you know, 4 or 5 months after the provisional has been in place. And, you know, I always like to remove these and assess and evaluate. You know, I felt like we had really nice thick tissue, but I thought, you know, the central incisors were a little long. You know, and this is our job as a, you know, as a prosthetic, you know, restorative dentist, and that's to, you know, at times shorten or lengthen, you move the tissue, and it can be accomplished with, you know, slight modifications of the prosthetic. So multi-unit abutment selection, right? It's pretty simple, straightforward for an FP3 case where, you know, we're creating a nice shelf, you know, mandible maxilla, and, you know, then we're just trying to get that, you know, elevate that multi-unit abutment platform far away enough from the bone where, you know, we don't violate, you know, those soft tissues and create, you know, inflammation. So, you know, this is directly from, you know, Neodent, and they're essentially saying, you know, you want a 1.5 millimeters above the crest of the bone before you start your prosthetic. So that's, you get too close to that, you're gonna potentially experience some crestal bone loss. You know, but this doesn't necessarily apply to FP1, you know, because we know that we need, you know, more tissue than just, you know, 1.5 millimeters. And so this is, you know, an attempt at trying to correlate Gomez Meda and Esquivel's paper to, you know, utilizing multi-unit abutments in FP1 prosthetics. So in this case, you know, your C zone is taken up by the gingival height of your multi-unit abutment, so that, you know, cuff height. And then the B zone, that bounded zone, is going to comprise, you know, the coronal portion of the multi-unit abutment, and then also extend sometimes into the prosthesis, you know, until you get to the E zone, where, you know, that's your gingival margin. And so for the implant planning, this is exoplan, And so a lot of times what I like to do is, have my prosthetic designed ahead of time. And then I'm going to place my implants based on where the multi-unit abutment is going to, intersect that wax up, that 3D wax up. And, from here we can make a surgical guide. With straight multi-unit abutments, it's pretty straightforward, right? With angle, it gets a little more difficult because you have, those measurements can be, confusing. So it's really nice, to be able to plan all this ahead of time, in a digital model, such as Exoplan. So is all this worth the trouble? Dennis mentioned that my background in engineering, so I'm automatically going to make things more complex than they need to be. But is it worth the trouble? I would say yes. This particular patient, she came in, she took a nasty fall down a staircase during COVID, and avulsed her entire right side, of the maxilla. And so for her, using the FP1 protocol was less invasive. We didn't go in and destroy a lot of bone. She mentioned that it was very, very little pain, post-operatively. Felt like we got a really, really nice result. Ultimately, this is, feels better to the patient. We're replacing just the teeth. There's less of a transition. The transition line feels more natural to them, than say an FP3 transition. Leads me into a case presentation. And so this was the first case that I used a facial scanner with. And, I'll show you in a second how I jumped the gun a little bit. But when I introduced facial scanning earlier this year and into our office, a lot of light bulbs went on, went off for me. The biggest being that, now that when I'm designing or pre-design, I've got the face as well as, the teeth. And we used 2D imagery for a long time, but this was something that allowed me to have the patient there. I think about it like being able to do a diagnostic wax up, a denture, setup, and be able to heat the wax and manipulate the teeth while the patient's still there. And so this was a pre-design for her. And so here's our smile design. I mentioned this was one of the earlier cases we did. I hadn't even opened up InstaRisa's reference screw. And so this was a reference screw that we're using previously in the palate. And we'll show you, where things kind of went awry a little bit here in a minute. But her case was a little tricky in that she was missing her lateral incisors, so she was deficient in the maxilla. But also she had very thin biotype, and a lot of this decay, class 5 decay. Those a lot of times lends for the soft tissue to be really thin and friable. So my plan on her was to do quite a bit of buccal augmentation, and with allograft, xenograft, and connective tissue grafting. So here's some pictures from her surgery. We did using a sausage technique or a rib roast type technique to tack those membranes down. We harvested soft tissue from the tuberosity as well as the palate. And so here she is, day of surgery, after delivering the prosthesis, and we allow this to heal. So here we are 2 weeks, post-operatively, and we're seeing good healing. We're seeing where some of the connective tissue graft is exposed just a little bit, but everything looks really, really nice. And so here's our 2-week post-op, and wow, she looks like, totally different person. And I look a little bit closer and I say, well, I've heard all these great things about, being able to use the face in treatment planning. Why do I have a cant? Why is my midline off? It doesn't match what my pre-design was. And the reason was I used my bone reference screw that had been using in some previous cases, and there's no anti-rotation features on these. So if you're a lab, or if you're a surgeon, or if you're a restorative doc, understand that anytime that you have an alignment error, it's going to affect something down, down the road. And these errors, these alignment errors compound, and can, luckily I'm not too far off, and maybe I'm splitting hairs here a little bit, but you just understand that those errors will continue to compound. So understand going into the surgery, what are you going to use to align those pre and post-op jaw scans, but also make sure that it's part of an overall workflow that's going to get predictable results every time. So that was, a little bit, shows a little bit of my ignorance there, just jumping into the facial scanner, but not necessarily, utilizing the entire workflow. But continuing on with her case, decided to do attempt a FP1 on the lower as well, which can be difficult. It wasn't her case, and so here we are, 6-month post-op, and of course on the maxillary arch, we just did connective tissue and some GBR with. You can really appreciate on that far right slide, the right picture, you can see the amount of bone that we were able to generate, there. And so I bet we're, I don't know, 8, 9, 10 millimeters from the implant platform. We should have plenty to support these tissues and prosthesis for a very long time. The lower, so I was a month behind on the lower, and actually, I hustled to get these photos last week, and so we did root banks on the lower. I didn't probably rush through this a little bit earlier on, trying to figure out Google Meet, but you do FP1, and if you don't take into consideration how to prevent the recession and the bone loss over time, crestal bone loss over time, then we'll end up with something that doesn't look quite so good down the road. So for me, it's if I don't have a tooth that I can potentially root bank, it's connective tissue and GBR. If I do have teeth, then I'm going to root bank them. I noticed, and again, this is a webinar, but I want to make sure that, I'm showing everything properly. I did notice, something caught my eye on this case, and it was this little part of this here. So I had the assistant, quickly snap a picture, or a PA, and boom, not good. So I've got a root bank on either side that I was hoping would hold, connective tissue, and now I've got a mess that I get to clean up, first week back in January. So did the implant get infected? Did a root bank get infected? Did I overcomplicate things? Did I over-engineer it? I don't know, but here we are. And the moral of the story is, this quote, I always come back to it. I'm sure you all are familiar with it. Perfection is not attainable, but if we chase perfection, we can catch excellence. So minor setback, but I think that's just kind of part of it. It's certainly part of my learning process, and I feel like not enough people really show their failures. So here's one of mine. So let's talk about InstaRisa and how it's really changed what we do and how we treat the client now. And I'm a little biased. I do lecture with InstaRisa quite a bit, and I met a lot of you on this call through InstaRisa. But I get these questions all the time. My goal is just to really just to help empower other clinicians, other doctors, to have the same kind of success that we've seen in our office with it. And all these questions pop up. Why do I need a facial scanner? I get great results with photography. You can't see the eyes with InstaRisa. So I want to address some of these, while also talking about these FP1s. So everything should be facially driven, right? Prosthetically driven, facially driven prosthetics, especially all important. We're doing full mouth rehabilitations. If we neglect the face, then we can get in trouble. And this is a case of a young man in that right quadrant, his maxillary right quadrant. It's showing a lot of gum there. He's got extra super eruption of those molars. He's got root tips there, and the sinus pneumatized as well. And so if you go into this case, you're not understanding where his smile line is, how are you going to communicate this to the laboratory technician? How easier to communicate this to the laboratory technician than an image, such as this? And so when you're treatment planning this, if you just go in and think you're going to take off, 10 millimeters of bone, you're likely going to end up with a transition line showing, a cosmetic failure. So with his, digital mock-up, that we completed for him, you can really appreciate the amount of reduction that would be required, and you're well into the sinus here. And so we haven't treated this case yet, but we're probably looking at sinus grafting, or I don't do pterygoids yet. Perhaps you can do a pterygoid and lift the sinus and still do this in one surgery. But the point that I'm trying to make is design these ahead of time. Do your you don't just go into this blindly. 3D mock-up ahead of time with the face is going to save you a lot of heartache, a lot of trouble, and make these a lot more predictable for you. So why do you need the facial scan? Can't you just use 2D photos? The problem with 2D photos is you lose your perspective. Right? You lose perspective with 2D. Even if you line it up, something's going to try to move a midline with 2D, and you've created an occlusal cant. Try to correct an occlusal cant, and you've created a midline shift, right? Versus using the face, you don't lose perspective. So what we design is going to be translated, to our prosthesis. So digitally design the prosthesis before surgery. So here's how her case turned out 3 weeks post-op. Connective tissue grafting on that one. 3 weeks post-op, midline. We deliver what we designed. And so do the best you can until you know better. Then when you know better, do better. I think I saw this, perhaps saw this quote on one of Art's lectures in the past, but it really rings true. Once I saw the ability and the predictability of the prosthetics using a facial scan, I can't unsee it. So better, then do better. Brings me to another case. And so this will be our last case presentation. But here we are with Tori, right? High smile line, shows a lot of gingiva on the maxilla. I'll tell you that we've got posterior super eruption. A lot of these teeth were treated with root canals and posting cores, but we didn't have, didn't get crowns on them in time. So we got a lot of fractures there. We got some periodontal issues. And so here he is. So I want to talk about the facial scanners just a little bit, because they're not all created equal. And I hear you already have a facial scanner, or do I really need the facial scanner? And the reality is, most other facial scanners that I've looked at, when you really look at the data that you get from them, not many of them are better than for instance, an iPhone. So I want to compare these two on his case as we're treatment planning him for FP1. So this is a retracted view of, we're going to call it scanner A versus InstaRisa. And so your issue here is, we need to be able to align the intraoral scans to the facial scan. It's much like trying to align, an upper jaw impression or an upper jaw model on a FaceBo. It's critical that whatever you're using captures enough details so that FaceBo transfer is accurate. There's no way you could possibly align these with that scanner on the left. Whereas with InstaRisa, there's just a ton of data there. Just a ton. The resolution is 100 times better. So here's the same comparison. Again, scanner A, with this natural smile, and then with InstaRisa. And here we are retracted. It's just no comparison. And here I have X scanner, and I'm using it and I'm getting good results. It'd be nice to have more competition for just the general population of dentists out there trying to get into these, but the reality is I've yet to see one that comes close to what InstaRisa is producing. So if you have one of those or you're looking at them, request the raw uncut data alignment, right? So what I mean by that is ask for an image and ask for the alignment of the intraoral scans, because what you're going to notice is they're getting close, but as I showed before, if you're off just a few degrees, you're going to create a cant. If you're off just a few degrees on these alignments, there's a good chance that you have a midline issue. So what you're seeing here in this little heat map, blue is zero discrepancy, and then going towards red where you have a little more difference. And of course, the InstaRisa there on the right, we've got blue and green everywhere. So it's a very, very precise alignment of the intraoral scans to the facial scan retracted, and then from our smiling facial scan alignment to the retracted facial scan alignment. And there's just no comparison. So this is the raw data from Tori's case. The workflow I used here, we're missing multiple posterior teeth, and the InstaRisa workflow for that is use a putty bite. And so we are able to 3D scan that putty bite and align the upper jaw and the lower jaw using the bite, and then aligning that to the facial scan. Here's our pre-surgical prosthetic design. So this is FP1, and it's almost treat this like a aesthetic crown lengthening case, right? So I'm planning where I want my gingival margin to be, and then I'm going to reverse engineer where the implant position is. So that's what that looks like here. I was able to go all straights here. And I created this Pontic guide. So this is similar if you've seen a multifunction guide or a Gallucci guide. Within exocad, you're a few clicks away from being able to design this, and the tooth position stays the exact same as what we designed. We just add a pallet and we cut a hole for the reference screw. This will play. What you're seeing here is I'm using this Pontic guide in order to determine where the tissue drape needs to be, but also here in a second I'll pull it back and I'm going to look at how close my bone reduction is. And so I'm going to go in.
What I need at least 2 millimeters. Right now I got about 1.
Sounds like I don't know if you can hear the audio or not.
I need a little bit more.
But so this is just a way to kind of utilize your design in the CAD software. And so if there's labs out there watching this is something easy to create for your docs. They can take this to surgery and use this kind of to plan that bone reduction, the scallop reduction. Some folks will use a scalloping guide. You can use I've gone in and measured from existing teeth. Again, it's like a crown, aesthetic crown lengthening, but then scalloping to allow for your Pontic position. So our artificial reference screw, if you remember that earlier case that I showed, there was nothing anti-rotational about it. With this screw that InstaRisa is designed, it comes in 2 parts. So there's a screw and there's a scan body that slides over the top of it. And what you're showing, or what I'm showing here, is the pre-op scan on the left and the post-op scan on the right with our implants placed. And then to align those two, you have the image in the middle. And the precision of alignment using this reference screw scan body is unparalleled in my opinion. I haven't seen another reference screw design out there like this. And so what it allows you to do is it gives you that confidence going from the face scan that you're going to produce your prosthetic that's exactly what you designed. So here we are, day of surgery design. You know, for this case, I took a putty, a bone level putty, so that my technician could go in and adjust those ponics to where we were correct distance, you know, from the ponics. This is 2 millimeters, probably 3 is a little bit better. Gives you a little bit of flexibility if you need to, you know, adjust your ponics apical in the future, because it's as I showed before, you know, once you get a failure on a ponic or on a root bank, you got to go back in and do a revision surgery. So keeping these ponics away from a root bank is paramount. And so on the left, I'm looking good. On the right, I'm a little close. But back to, you know, the point of using the facial scan. You know, we want to deliver exactly what we plan. And so this is a combination of the accuracy and precision of the InstaRisa facial scanner, being able to pick up the intraoral scans of the pre-op, and the precision of using the InstaRisa artificial reference screw along with the scan body to be able to accurately and predictably align the pre-op scans and the post-op scans. And if you look really closely at that right image, you know, he's a little deficient in that left buccal corridor. And if you look at my design, it's designed exactly like that. And so if I know that I've got good facial records, I've got good intraoral scan records, you know, going into a surgery, if I know that my reference screw hasn't moved, if I know that I've followed the workflow to the T every single time, I should see the prosthetic that's delivered match my pre-design precisely and accurately. And I see a lot of posts out there. You know, you go on, you see great cases on Instagram. It's a great learning tool, you know, but you see a lot of people out there that will show a facial scanning workflow or a digital workflow, and you'll notice midlines off. You know, midlines are off. Everything's candid. And, you know, I'll be honest, I fell, we just kind of said that was part of it. You know, we would even tell the patients, you know, hey, you're getting teeth today. We're designing them on CAD CAM. We're going to get close, you know, but the goal is to, you know, be in field goal range, right? But you may have a midline off, or you may have an occlusal cant, you know, but we can adjust that. We can address that. On Tori, we're dead on. You know, I'm not sure that we're going to, you know, I may make a few slight adjustments where the soft tissue is, bring some of those ponics down and adjust a little bit, but for the most part, we're done. You know, it doesn't get more predictable than this. And so imagine having an occlusal cant before you even go in, you know, to place these implants. And, you know, what if you create an occlusal cant with your bone reduction on an FP1 case? You know, you're dead in the water. So here we are, you know, 4-month post-op. You can see our root banks. You can see where I'm a little close, you know, on that right cuspid. And so here's our treatment progression, right? So from our beginning to our, I think that middle image is probably, you know, 3 or 4 months. And then, you know, where we've shown the soft tissue there, you know, on that lower image. So I apologize for the slow start. I apologize for my, you know, rusty skills with Google Meet, but I hope this, you know, kind of shed some light on some of the things that we're able to do with a predictable workflow. You know, hopefully it kind of highlights some of the considerations for FP1 prosthetics, you know, surgical and prosthetic issues and hopefully you took something from this. I'll finish this with you know, a quote that we see a lot, you know, in our InstaRisa courses: none of us is smarter than all of us. And so there's the you know, take a picture of this if you're not already on the WhatsApp group for the InstaRisa tribe. And with that, I'm going to turn this back over to Dennis.
Thanks a lot, Keith. Did a fantastic job. Really appreciate that. What I'd like to do from here is open up to some questions. And let me kind of help folks navigate getting to the questions area on Google Meet. So if you look at the bottom right of your screen, you'll see this image here with the triangle, square, and circle. So if you want to click there, that will, like I said, bring up the questions, and you'll be able to type those in, and Dr. Klaus can respond. So give everybody a second to navigate to that part of the screen and type in some questions. Okay, we got a hand raise here from Dr. Tharp. I'm sorry, Dr. Tharp, I don't know how to get to the hand raise section on this.
How to navigate Google Meet 101.
But here we've got a question from Dr. John Brockloff. Says, Keith, can you speak to the different heights used in the MUAs in an FP1 case?
Yeah. So the idea, and if you go back, I don't even know if I'm not even going to try to go back to that slide. You know, but overall, we're probably going a little bit deeper than with FP3. You know, my goal is to be typically about 5 millimeters with the implant platform below the gingival margin. And so if you start doing the math, you know, if you go look back at those EBC, you know, you're looking at a you know, platform, you know, being 1-2 millimeters below that gingival margin for your multi-unit abutment. And, you know, so I'm typically in the 2.5 to 3.5, you know, gingival height range for the multi-units. Not sure if that answers, hope that answers the question.
Here was a follow-up of, you know, how do you clinically decide which height?
So I plan it ahead. I try to plan it ahead of time. The goal is to plan all this ahead of time and use guided surgery, you know, to nail the site, the position. I think you almost have to be guided with FP1 if you're going to pull them off. You know, clinically, if I'm going to, you know, try to do this clinically, you know, I try to err on the, you know, side to be a little bit deeper.
Beautiful. We got another question from Smile Pro Dental here, asking us, what will be the first step to start doing an FP1?
Evaluate the high smile line, right? Start off with, you know, facially, you know, driven, right? So first identify, what are you trying to restore? Are we restoring, you know, soft tissue and the teeth, you know, gingiva and the teeth, or you know, or do we have a high smile to where, you know, in order to do a FP3, you got to take away, you know, 15 millimeters of bone? You know, that's where I start.
Beautiful. Thank you, Keith. We got another follow-up on the multi-unit question from Dr. Brocklov asking, do you ever change the height after healing?
All the time. I try not to. You know, the whole one abutment, one time concept. I think there's a lot of value to that. You know, but I can show. I've got cases where I've changed not just the height, but I've also changed the angulation of the multi-unit abutments. And, you know, that's another reason to try to, you know, plan these with the 2.5, 3.5, you know, millimeters, so you can go, you know, higher or lower depending on where you need the zenith of that gingival margin.
Beautiful. Thank you, Keith. Here we've got one from Dr. Jaime Romero asking if do you get a high degree of broken temps with an FP1?
Higher than it depends on the material, right? So I'd say with our printed materials, yes. Obviously, it's thinner. To counter that, often I'll bulk up the lingual, and just in general, you're trying to keep a one-tooth ponic when possible. So if I see a lot more failures with two-tooth ponics, and obviously no cantilevers. Try to reduce the amount of cantilevers. If I have a repeat, if I have a patient that just seems to break these over and over and over, sometimes we do have an in-house lab, so sometimes we'll try to mill out a PMMA, or on some bruxers I've even done cheap zirconia.
Beautiful. Thank you for that answer, Keith. Just scrolling through the questions here. We got another one from Smile Pro Dental asking, when will you have your FP1 course coming up?
We've talked about doing one at Atlantic Implant Institute. We've talked about doing them with InstaRisa. We've got one I think we're going to maybe do with Negagen. As I said, it's just a work in progress, for me, so I feel like I'm far from a master, but I definitely have enough cases to where, I know some things that I don't know, and I know that there's a lot of things that I don't know.
Well, I appreciate you sharing with us what you do know, Keith, and I know from knowing you personally and professionally, you've got a lot to share with the world of dentistry, and I appreciate that. And I think this was very informative. Obviously, FP1s are beautiful. They're patient friendly. They're a little bit intimidating for some clinicians, but I think you've made it much more approachable, and definitely appreciate you showing the benefits of utilizing the 3D facial designs, and the scanning from InstaRisa is fantastic. So it looks like, I'm looking here, I don't see any other questions. So I got a couple of things I'd like to share with everybody to close out the webinar. For everybody who has spent the time with us this evening to learn about FP1s, we'd like to extend to you a discount if you want to register for an InstaRisa course. Please visit www.instarisa.com/course-calendar. We're giving you a promotion for this evening only. This is going to end at midnight Pacific time. We'll give you $500 off any course if you enter the promo code FP1KING. And that is, again, FP, the number 1, and King, as in Keith Klaus, is the king of FP1s. So please come join us at a course soon. Also, to reiterate what Dr. Klaus mentioned a few minutes ago, please join us on our WhatsApp group. If you're not already a member of the InstaRisa tribe, you're definitely missing out on some great clinical nuggets, some case reviews, and also some phone a friend bailout type situations if you have a clinical challenge and you want to consult with a highly skilled group of professionals that are very motivated to help patients and help each other. That's what the WhatsApp group, the InstaRisa tribe, is all about. So please join us, and we hope to see you there. And I'd like to leave you all with a sneak preview of another project we're working on, which will be coming to you in 2024. The InstaRisa Face the Future podcast. So stay tuned. We'll be making announcements about that. We will have a special guest for our first episode that you won't want to miss. So please stay tuned. And with that, folks, I do want to thank you all for joining us as we kick off this webinar series. We're very excited to be able to bring some unique clinical perspectives from some very brilliant clinicians. And I think we started off in a fantastic place tonight. So thank you, Dr. Keith Klaus, for sharing your knowledge of FP1s with us. And thank everybody for tuning in. and hope you have a wonderful evening and a Merry Christmas. Take care,
Excellent.
everybody.